Welcome everyone on the call, and welcome to Professor Trish Greenhalgh. She will be talking on a topic that's a pressing issue for so many of us: how to increase the success of our technology projects in the face of complexity. Basically, how can we make sure our technology projects actually deliver? Trish trained as a GP and is currently Professor of Primary Care Health Sciences at Oxford University. She's a renowned academic internationally and leads a programme of research at the interface between social sciences and medicine. She also leads a double life as simultaneously an ardent supporter of evidence-based medicine and also a strident critic of the relentless pursuit and application of research evidence at the expense of considering the patient as an individual. Her guiltiest pleasure, apparently, I don't know if that still stands, is Wagner.
Yeah, oh God, that somebody interviewed me about that. Yeah, was it the BMJ?
Yeah. That's where I found it.
When I'm admitting to.
This call itself is brought to you by a special interest group that is part of the Q community of healthcare improvers that Penny just told us about, which I'd encourage you to join if you're not already a member. The link is in the chat. The SIG itself is called Closing the Gap, Developing Improvers for a Complex World, which focuses both on the complexity we see in our healthcare systems, as well as the inner complexity we arguably need to nourish and enable in order to be able to cope effectively with that external complexity. Please join the SIG's online space if you want to hear about future meetings or access the recordings of previous meetings, including this one. Previous ones include Professor Mary Uhl-Bien on innovation in healthcare and the crucial role of adaptive spaces. In fact, there's also going to be an online reading group about adaptive spaces and Mary Uhl-Bien's work in February if anyone's interested. There's also Professor Sofia Kjellström from Jönköping on how understanding adult development can enable transformative improvement. We also had Jennifer Garvey Berger about the inner change being the next frontier of improvement. And Q member Esther Hall spoke about using Dave Snowden's SenseMaker software to enable public health projects. And Esther's the leader of this TIG with me, but unfortunately found out on Monday she wouldn't be able to join us today, so sadly she can't be here. Please keep yourself on mute unless you're asking a question. And also, if you could all introduce yourself in the chat box if you have access to it, and share why you felt attracted to join this Zoom call with Trish. And feel free to share your guiltiest pleasure too if you want to divulge that. We'll record this meeting and share it afterwards. So if that means you need to be careful what you want to say, please do that. And we'll probably share it on YouTube as well. We've just set up a community channel for Q on there. And I think Trish plans to take questions at various points through the call rather than bunch them all up at the end. Just so you know. And over to you, Trish.
Brilliant. Oh, well, thank you very much. Welcome, everybody. Thanks for giving up your lunch hour. Yeah, I think I'll just go through the trying to share my screen now. And we just had a dress rehearsal on this. So can someone confirm that you can now see the first slide?
Certainly can.
Yes, can see that.
Great stuff. Oh, well, that worked well then, didn't it, that rehearsal? So I've been asked to talk about how to improve the success of technology projects in health and social care. And I guess, look, I don't have to tell you guys that technology projects are hard. And what I mean by a technology project is you're trying to do something, and that something includes either introducing a new technology or trying to get people to use a technology that's kind of been around but isn't really being used. And most change projects these days involve technologies, and most of them involve software. And that's very different from when I first started doing work on innovation and change in the healthcare field in the early 2000s. Quite a lot of change projects didn't involve any technologies, or they didn't involve apps or robots or anything like that. And the trouble with software in particular is it's a very fast moving thing. You're always getting these upgrade notices. So the technology is different this week from what it was last week, and so you're constantly trying to keep up with yourself. And I'm going to present, I think I've got about 12 or 14 slides, so not a huge number. So hopefully we'll be able to, stop and take questions and comments. I actually can't see the chat, the sidebar with your chat on it now. So when I stop, if someone, Mark or someone can read out the kind of most interesting looking questions. Anyway, what I'm going to be telling you about is based on something called the NAS framework, which stands for non-adoption, abandonment, and challenges to scale up, spread, and sustainability of technology-enabled change projects. We are also interested in the adoption of technologies, but ANAS wasn't such a good kind of acronym. But the problems with these projects are non-adoption and abandonment of technologies by individuals, and then three things that happen at organizational or system level, which is scale up doesn't happen. In other words, it just stays as a demonstration project. Spread doesn't happen. In other words, it just stays within your organization, but doesn't go down the road or to another, town or country. And then sustainability, which is, it looked like it was going all right, and then the key person who was driving it has left, and so it all fades out over time. So if we think about NASSS as the set of problems, I don't have any simple solutions, by the way. So don't think you're going to get to the end of this talk and have a quick and easy way of solving those problems, because you won't. All right, so how did we develop the NAS framework? I mean, apart from doing a systematic review of the literature, we were looking at a number of in-depth case studies. And so the work we did was based on a 3-year program of work. We looked at the introduction of video consultations in the NHS, which is something that suddenly has become really topical because it's in the NHS long-term plan. 1/3 of consultations are going to happen by video in the next 5 years. Some of you may have seen my letters to the Times and my piece in the Conversation saying, I'm not sure that's actually going to happen. Why is it so hard to get video consultations up and running? We looked at M-Health, gadgets for epilepsy. These are things that look like Fitbits. You strap them on and they'll tell you that you've had a fit in the night and you didn't know about it. It's supposed to be transforming epilepsy care. In fact, the uptake of these technologies is still very low. Risk analytics, which is a very heavy kind of IT, drawing data from general practice records, social care records, secondary care records to try and give patients a risk score and identify the people at risk of readmission or frequent flyers or whatever, so that people can go along and try and prevent those admissions. There's pendant alarms, probably don't have to explain those. Various kinds of telehealth for heart failure, including implantable devices, but also little blood pressure monitors and blood oxygen monitors that people use at home. There's care organising apps, which are interesting. You may not know about these ones, but if you've got an elderly person living alone at home who needs the relatives to organise themselves around who's going to visit granny, who's going to pick up the milk, who's going to take her to the doctor, there are now various apps that you can use to keep in touch with your other relatives to make sure that somebody picks up all the things that need to be done. Jointly is the one that I've illustrated. And then there's GPS tracking for dementia, which is a thing like a wristwatch that you can wear if you've got cognitive impairment and you want to still go out and walk the dog, but you're not sure that you'll be able to find your way home. And then if you get lost and you don't turn up at home when you're expected, an alert gets triggered and someone come and find you and take you home. You can imagine that has all sorts of issues around it. So what we were doing was looking at lots and lots of different projects, all of which were trying to improve care for a particular group, either social care or healthcare or both, and there was a technology involved. So that's where this came from. Are there any questions coming up so far, or shall I sort of zoom in a bit more to what I'm going to say? No questions. Are you muted? Because if you're talking to me, I can't hear you.
Sorry, Trish, that one question just came in from Andy Ware. I don't know whether it's something for later or now, but he said, did you get an answer to your recent tweet saying what technology has worked in A, but not in B or C?
Oh, that was something else, wasn't it? That was scale up. Yeah, but that's totally irrelevant to this lecture, so I'm not going to talk about it now.
Sorry,
but it's nice to know that people are posting stuff. Okay, you've got to post stuff that's about this lecture, otherwise I get confused, all right? Okay, so here's my complexity slide. Now, some of you are experts on complexity. Many of you are, well, I was looking, you're service improvement facilitators, or you're working in the down and dirty of NHS or social care, and you will experience complexity. You know, you may not be able to define it at a theoretical level, but you sort of think, God, this bit of my job is complex. And that subjective feeling of complexity will do, probably. Actually, it's quite a good barometer of whether something's complex. So what I mean by complexity, well, let's start off by what I mean by simple. This is something that is straightforward, it's predictable, it's usually got very few components, and I've illustrated that with making a sandwich. And then there is something that's complicated, which is really just like simple, but scaled, you know, there's more interacting components. And I've used the example of building a rocket. You know, if you follow the instruction manual for building a rocket, you're going to get the same rocket every time, which is why simple and complicated tasks have been joined together on the left hand of the slide. They're following the same logic, just keep following the protocol. On the right, and those of you who are parents will know this feeling, there is the complex issue of raising the child. This is an example of something that is very dynamic, it's unpredictable, and you can't split it off into constituent components. You know, the child is the child, and that is complex. If you've had more than one child like I have, you know that following the same things that worked with child one just don't work with child two. Because of all sorts of, because it doesn't follow simple, predictable, linear logic. Now, what I'm going to be talking about today is complexity as it pertains to technology projects. And complexity there can be two kinds of complexity. One is logistical, or it's sort of structural complexity related to the number of interacting parts. And then there's socio-political complexity, which is about all that interpersonal stuff, people with vested interests, people with funny personalities. I had one this morning, actually, at a meeting at one of the trusts, and they said, oh, yeah, well, the director of nursing is not interested in research. That's a socio-political complexity, because we were then discussing, well, how can we get this person on board or move around them? It's not something that tends to be in the manual. So think about logistical complexity, but also socio-political complexity. Now, Harvey Mailer, who's a colleague of mine in Oxford, he works at the Surrey Business School, and he's done some research that suggests that 80% of complexity in projects in the workplace tends to be socio-political. But when you get the guidance on how to manage complex projects, 80% of that guidance pertains to the logistics. And that's a bit of a problem, really, that we don't tend to get our heads around the socio-political complexities. We tend to sort of dehumanize it and think it's all about logistics. Now, are there any questions about complexity in general before we get on to how it applies to technology projects?
I think we've got one from Andy. Is that Andy, do you want to unmute and ask your complexity related question? Andy, where? If you can't unmute, shall I
Yeah, I was going to say we can't hear you, Andy.
Sorry, he said it's too noisy where he is. Do you just want to ask his question instead?
Yeah, so is that the question there that I can see?
Isn't scale up important with adoption, question mark?
Yeah.
Knowing whether it can scale, whether it will adapt sensitive dependence on initial conditions currently.
Yeah. Did you hear that, Trish?
No, can you repeat it? It was a little bit not very clear.
Yeah, maybe this is a bit of a scale one again. Isn't scale up important with adoption? Knowing whether it can scale means whether it will adopt. Sensitive dependence on initial conditions?
Well, yeah, dependence on initial conditions is one of those things that the theorists in the complexity theorists quite like. This is pretty obvious, actually. You do a project in one place, and then you try and repeat the project, you know, in the next place down the road, and it just doesn't work. And then you get someone to tell you the story of what's been going on in place B, and you find, oh my goodness, if we'd only known that was happening, we wouldn't even have tried to get this project off the ground. Now that's giving you a sort of narrative summary. I mean, there are mathematical arguments that you can have for this sensitive dependence on initial conditions, but yeah, it's absolutely key. It's absolutely key. Other things about complexity theory, things are non-linear. A very small input can lead to a large output, or vice versa. You don't have a fixed effect size. But let's not go too into that, because I think, you know, this isn't a talk about theorizing complexity. It's a talk about how does complexity actually play out in technology projects. And to be honest, I don't think it's that hard. You don't need to be someone who can do the mathematics of fractals to get this. You can just think, hang on a minute, I'm experiencing this as subjectively complex. And Harvey Mailer, who's a professor of complexity studies, says that's the best way, the best canary in the coal mine as to whether something is complex is, are you experiencing it as complex? Okay, so the NAS framework, which is explaining these problems of non-adoption, abandonment, and barriers to scale-up, spread, and sustainability, the NAS framework has 7 domains, of which the first is the condition or illness. And you can see here that we've got simple or complicated represented by a broken ankle or cancer, and then complex represented by dementia. In other words, some illnesses are complex in the sense that they unfold unpredictably. There's lots of different interacting variables. And don't forget the socio-political complexity. Any of you who've ever looked after a relative who's going through dementia, and I have, will know that there's a lot of interpersonal stuff that make this a really difficult condition to manage. Now, if you go to, I gave this talk at Macmillan, and they said, well, cancer is often complicated. What I mean by that is, look, you know, when you get diagnosed with cancer, you have to have an operation usually, you have to get chemo, you have to radiotherapy. It's all very complicated, to the extent that you have to almost get your diary blocked off with all the different things you've got to have. But actually, they will be able to tell you what the treatment's going to be, and they'll be able to give you a pretty good idea about your chances of survival. Whereas with dementia, it's not the case. And in many of the case studies that we looked at, the complexity, the unpredictability, the dynamic nature of the illness was something that the technology enthusiasts and the change enthusiasts had not factored in. For example, in epilepsy, you know, you think, well, what is epilepsy anyway? And the clinicians on this call will know that epilepsy isn't a single condition. It's the manifestation of many different underlying problems. And we did some ethnographic work in an epilepsy clinic. And of course, some of the patients had what's known as pseudo-epilepsy, which is basically a psychiatric condition where the fits are not organic, but they are some kind of demonstration of distress. Now, that's going to be a very different condition to manage than an epilepsy that's caused, for example, by a brain tumor or you know, something you're born with. So complexity in the underlying illness was something that we found again and again had not been factored in to the design of the technologies or the design of the service around those technologies. Have I got any comments or questions around the illness?
Not around the illness. Let's push on.
Let's keep going. Okay, that's probably relatively straightforward. Now, domain 2, unsurprisingly, is the technology. And I've given you an example of a simple technology, an old-fashioned black telephone. You know, you pick it up, you dial the number. Now, there are things about those old-fashioned technologies. It's dependable. Almost everybody had one in the 1960s. I remember we had one of these in our hall. I don't think it ever broke down. It didn't do very much, but you knew where it was, and it, you know, you never had those things like you're breaking up, I haven't got any signal, you know, those kind of things. What else? It was easy to use. You knew exactly what data you were getting. All you were getting was the voice of the person on the other end of the phone. All that kind of thing. And there weren't any issues about who owns the IP or who's going to hack into this. Now you look at this complex technology, you know, our data analytics, machine learning stuff, and I'm sure there are many people on this call who know more about that than I do. There are all sorts of, you know, problems and challenges with that. The material features of that technology are highly complex. It's very difficult to describe what it is. You need to hire someone with a special skill set to use it, and it generates knowledge that is itself quite complex. You know, you might get an aggregator, you know, I mean, the whole business of what is this algorithm anyway? You know, it's because the machine has learnt it. Even the person who built the algorithm probably won't know how that knowledge has been generated and what that knowledge actually means. Then there are questions around the supply chain or the supply model of the technology. You know, if you were an NHS purchaser and someone came to you and said, this wonderful whiz-bang technology, the trouble is you wouldn't want to buy that if there wasn't a backup, if that supplier went out of business. So, you know, ideally, all the technologies we were relying on would be using industry standard components, and they'd be something you could walk into Dixon's and buy a replacement if necessary. But actually getting tied into what might be called walled garden contracts is another thing that makes technologies in the public sector just more complex. And then there's all the questions about who owns the IP. You know, is this company going to train their algorithm on NHS data and then run off and sell you that data back when the algorithm actually should be a public good? Because hang on a minute, whose data was it? So all those arguments. Now, I bet there's some questions or comments about the complexity of technologies. So what have you got for me?
The questions are sort of maybe other things that maybe we could do a bit later.
Okay.
Are there any particular technology ones?
I think people are flagging some projects that they've been involved in, but unless people have a specific question they'd like to pose, I suggest we move on.
Okay. So this is a huge domain, the technology. Now, linked to that, suddenly I can't move my stuff on anymore. I'm not quite sure why not. Just a second. Oh, look at that. I'm stuck. Oh, hang on. I think I can move it on. There we are. Right. Sorry about that. Okay. So the third domain in the NAS framework is something called the value proposition. And in order to explain this, I'm going to actually give you two examples. Now, you could call it a value chain, and anyone who's done health economics, or indeed anyone who's worked in the real world, will know that a technology that you're thinking of buying or thinking of investing in has got to generate value. And ideally, it's got to generate value for everybody involved in that, in the project. In other words, the stakeholders. So here's an example of a simple value proposition called the non-invasive liver biopsy. That's not its proper name, it's what everyone calls it. The idea is that instead of doing repeated liver biopsies on someone with liver disease, you do these fancy scans, which the clinicians among you will know that that's a slice through someone's middle, and it shows the liver on the left of the slide because you look from the feet up. And you can see the liver is sort of orange and green and red and blue, which is wonderful. In other words, you get an awful lot of detail in that scan, which allows you to manage the person's liver disease without sticking a needle in them. Now, that's good news for the patient because they don't have to have the needle stuck in them every few weeks. It's good news for the hospital because they don't have to bring the person into a hospital bed. It's good news for the person who's developed this imaging technique because it's actually relatively cheap to do, and you get a lot of business from the NHS. It's also good news for the blood bank, because when you do liver biopsies, you have to cross-match blood and be prepared to give them a transfusion in case they bleed from their biopsy. So everyone in that value chain, including the patient, gains. The example of the complex technology or the complex value proposition is something called a robotic wheelchair. Now, you won't see many of those around because they never got off the ground, because most people who are wheelchair users don't need a robotic one. They just need a basic one they can fold up and put in the boot of the car, and they can wheel it around, or their partner can wheel it, or whatever. But why the robotic bits? You know, it's like a self-driving one. Very few people wanted them, and the ones who did want them didn't want it designed the way that was designed. So within the value proposition, you've got both what they call the supply side value, which is, hang on a minute, if I'm the person developing this technology, will I be able to sell it and recoup my investment, or if I'm a venture capitalist? And then you've also got the more health technology assessment questions, the demand side value. Is it what patients want? And then is it, what's the evidence of efficacy, safety, cost effectiveness, that kind of thing. And I'm hoping that afterwards we'll have some examples from the people listening in of either good or bad value propositions in relation to your own activity. Have we got any comments on that at the moment?
So there's a kind of interesting train going on about whether if we co-produced technology with patients and carers more actively, whether that would be a good way of getting rid of or possibly hiding some of the complexity that comes in if it's predominantly led by technology developers.
Yeah, absolutely. And there's a woman in Canada, Pascal Lehoux, done some great work on this, that it is absolutely amazing how some of the technologies that have been developed, which, you know, if I put my GP hat on, I think, yeah, that would be a really good idea. And then you talk to patients who've got the condition and they say, no, we don't need this technology. Not only do we not need it, it actually is going to make our lives worse. And then they explain why from the perspective of the patient experience. And yes, co-design is absolutely key to getting a technology that is, first of all, usable, which is the previous domain, but also which generates value, which adds value. And in our heart failure case study, where we had all sorts of telehealth technologies, some of the technologies really added value, and the value they added was reassurance. So, you know, if you've got heart failure, you quite often think that your heart failure is about to kill you, because sudden death is a complication of having advanced heart failure. And one of the things that these technologies did was that they gave the patients a sort of quantitative indication of, frankly, how bad they were. And that was very reassuring. So you might feel a bit breathless, but then you'd check your blood oxygen level and you'd find that it was actually 93, and that was pretty good. And so that generated value for the patient, and it reduced the amount of contact that they had with their GPs, for example. Anyway, I should get on. So value is not just financial value, and that's actually quite important. I'm just going to turn my screen so that you don't see all the people walking past my office.
Trish, I could just raise a very quick point.
Karen Ritchie, Trish?
Yep.
There's one from Karen Ritchie just saying, how frequently can a technology deliver value for all stakeholders, patients, service provider, politicians, and the wider population?
Yeah, great question. And of course, value, something that generates value for me, the GP, might reduce value for you, the hospital doctor, or something that generates value for the patient might actually generate problems somewhere else in the value chain. And the video consultations one is quite an interesting one there. So the NHS long-term plan, and also actually I think Matt Hancock himself, but certainly others, have been saying video consultations are much more convenient for patients and they're going to free up staff. So there's value both sides. But actually what our research shows is that there's definitely a value to the patient, who doesn't have to get 3 buses and sit in a waiting room for, however late you're running. But in fact, for the healthcare provider, certainly in the early days of providing video consultations, there is no freeing up of staff. You know, the doctors and nurses have still got to sit in clinic. They're just doing a remote consultation. They weren't traveling anywhere anyway. And you're now having to run two different services, the face-to-face clinic and the remote clinic. So you need, if anything, more infrastructure. So that's quite a good example of something where the value proposition has not actually been worked out, and people are assuming that because it's so much more convenient for the patients, it will also be convenient for the health service and it will save money, and they haven't actually demonstrated that yet. Anyway, shall I go on?
Yes, do.
Okay, so I've just realised I've got to click a different button. There we are. Okay, so what we've got here is the potential adopters. So I've called the domain the adopter system, but what I mean by that is people, staff, patients, and other people who might be involved in the technology, so the care network. Now, I've given an example here of a simple technology, the pendant alarm. And at last count, I think there were more than 250,000 people in this country who were using these alarms. And you can see how simple it is. It's got a red button in the middle of it, and all you have to do is press it. In fact, it's complicated rather than simple, because you can just imagine the infrastructure that has to be in place in order for the right kind of response to happen when the person presses that alarm. And it's also not quite that simple, because the person pressing it has got to be capable of pressing it. So if you're in the middle of an epileptic fit, you're not going to be able to. If you've taken it off to get in the shower, you're not going to be able to. But also, if you're not sure what is or isn't an emergency, you won't press that button at the right time. And we've had examples in our own, in our case studies of someone who's been lying on the ground for 4 hours, not able to get up, but didn't press the alarm because they were pretty sure they hadn't broken anything. Whereas, of course, really, if they're lying on the floor, we'd rather they press the alarm and were rescued, even if they hadn't broken a hip. But the much more complex example is the GPS tracking technology. You can see I've called it granny tagging, because that's what some of the social workers in our study called it. They didn't want to get involved in this. They saw it as an aspect of state surveillance. Now, you could say this is a liberating technology. You know, it's an empowering device, because it means that someone with mild or moderate cognitive impairment is free to go and walk around their own neighbourhood, and the tag only gets used if they don't come back. But that wasn't how some of the social workers perceived it. So I think there are questions here about the complexity of the professional role and how that changes as a result of introducing the technology. And the social workers were saying, well, hang on a minute, you're making me an agent of the state, you know, putting these tags on. And the tags are actually developed in a parole setting. So the technology was developed to help implement court orders, like you're not allowed to go within 200 yards of your ex-wife's house. And so it was to control and restrict people's freedom. And somehow that had mapped across. So I think that's why it's complex, is that, you know, we want to use it for one thing, but the staff interpret that technology as being much more sinister. Any questions or comments about the users of the technology or the intended users?
There is, shall I read out Anna Burhough's stuff? There's one from Anna Burhouse. I don't know if you're there, Anna, and you want to ask it yourself, or else I could read it out of the chat. Do you want to unmute yourself, Anna? Maybe not. I'll read it out for you, Trish. Often the impact of technology has an emotional cost that's rarely measured.
Yeah.
For example, self-booking into a GP clinic might be great for people that value their privacy and hate to queue, but a real downside for someone that is lonely, for whom the chat with the receptionist is their only human contact all day.
Absolutely. I personally have been recently in precisely that situation of taking an elderly relative to see the GP and having one of those self-booking things, and to see the emotional effect on my relative was staggering, and you know, I tried to take her through it. Of course, going to the doctor is an emotional experience, and hopefully a reassuring experience and a positive experience. And so putting up these technological barriers. Carl Weick's done a lot of work on the interpretation of a technology in an organization. And actually the heart failure case was another one that we got a lot of data on. That some patients found, I know what it was. It was a set of weighing scales that were very, very accurate. And so you could sort of assess whether or not the person had got some accumulated fluid, which of course you don't really want when you've got heart failure, because it implies your heart's not strong enough to pump it out. So weighing the patient every day is quite an accurate way of monitoring, you know, how bad the heart failure is today. Now, many patients found that quite reassuring, and the doctors and nurses were very happy to get this accurate data. But guess what? Some of the patients, particularly some of the women, really didn't like it, because they got on the scales and it looked like they were getting fat. And they were interpreting this daily weighing as monitoring their body fat rather than how much fluid that they'd accumulated. And so they were interpreting this as very intrusive, but also rather stigmatizing. And they'd say things like, well, I never used to be 11 stone, as if we really cared how much their body weight was. So yes, absolutely. These emotional feelings can be very, very powerful and very upsetting, both for staff and patients, actually.
We've got for you, Trish. Penny, were you going to?
Yeah, so there's an interesting thread about the relationship between the different domains. I don't know if you're going to cover that later.
Yeah, we're going to come on to that. So save that one, park that, because I'm going to go through through these domains and then come on to to integrate them, because that's exactly what happens. Now, this is the organizational domain, and this is in a way the biggest domain, because some organizations are not really very capable of innovating, and some of them are not ready for particular technologies. I mean, you know, some hospital departments are pretty ready for video consultation, and others just are not there yet. And then there's all the questions around funding decisions, and also the implications for routines. In other words, if we introduce this change with this particular technology, who's got to do their job differently, and how have different team members got to interact with each other differently? And then there's all the work around implementation. So in a simple situation, you have an organization that's frankly got its act together, that is reasonably happy, you know who's in charge of which bits. There's a good fit with the technology. There's a bit of slack resource. In other words, there's money and staff that can be allocated to looking at the technology and implementing it. And the work is well aligned with existing organizational routines. But actually, with most of the cases that we looked at, there was a lot of trouble at organization level. Typically, actually, you had a technology that needed one organization to have a subcontract or at least a letter of agreement with another organization, which described how the money was going to flow. And two different boards had to both make a decision that, yes, we will fund this, when the savings were going to be generated in one organization, but most of the work was going to be done in a different one. That can be quite awkward. There was also the question of if the technology disrupted existing work routines, it was going to be much harder to implement. So the organizational dimension is something I've slightly glossed over there because it is so complex. But if you want to sort of know more about it, I would take a look at some of the papers that we've published. It's a huge domain, and it's really important. I'm going to sort of go through the last couple relatively quickly. The wider system is the sort of contextual issues, and I put them down on the left-hand side. You know, if you've got a policy push, which we have for tech at the moment, that's good. Regulatory and legal hurdles, you know, has this device, for example, got the right regulatory approvals? Is it legal to use it? Does it breach, you know, confidentiality regulations, that kind of thing? Are the professional bodies behind it, or is the Royal College of something or other saying, no, we don't want our professionals to use it? What are the press saying about it? Are people sort of seeing this as a breach of somebody's rights? And then there's all the things about interorganizational networking, and you'll know all about that being the Q community, how powerful it is to have people in other organizations who are already using this technology, giving you advice about how to set it up in your organization. If there's already a strong interorganizational network, that's going to make things a lot easier. And so you can see that in a complex situation, you've got all these tricky externalities, and also that possibly you're the first group that are doing this. And we've got this with video consultations at the moment. There just isn't enough. There isn't enough of it going on yet. And there's also still questions around things like tariff, which means that the externalities are quite problematic. Hopefully we're going to solve those quite soon, but you know, don't quote me on that. Okay, so let me tell you about the last domain, and then we can have a bit of a discussion. This is about the scope to adapt to a changing world. You know, remember that everything's very dynamic in complex systems. So how resilient is the technology? You know, can you adapt it? And so many technologies, you know, they're fixed, which is no good. You know, are you able to upgrade it in 9 months' time when something else will have come on the horizon? And similarly, the resilience of the organization. To what extent is the organization capable of weathering external shocks and adapting to the next thing that comes on the horizon? I've used the word brittle here because, you know, brittle technologies are ones that you can't fiddle with. And you can also have that phenomenon in organizations. So, just having trouble. So here's the NAS framework all pulled together. The condition, the technology, the value proposition, the adopter system, the organization, the wider system, and then how all that unfolds over time. And these are the things that our research, and also the research done by others, have demonstrated really makes a difference to whether or not a project is going to work. And the more areas of complexity you have in more domains, the less likely things are going to go to plan. So let me just tell you a little bit about what we're doing to apply the NAS framework to the real world. And I'm working with Harvey Mailer on something called a NAS-CAT complexity assessment tool. So this is a sort of self-assessment. It's more than a checklist, it's a sort of guide to introducing technology. So the first thing you need to do is apply the NAS framework to tease out the uncertainties and the interdependencies in your project. You know, do you really understand where the complexities lie? The second bit of the NAS-CAT tool is, can you reduce complexity? And the idea is we want you to reduce it as much as possible. Make this a simpler project, make it, you know, slightly smaller scale, try and reduce all those interoperability issues. Does it really need to be interoperable with everything? Try and stretch out the pace perhaps. And then if you can't reduce complexity, then how can you run with it? How can you handle the complexities to manage them? And you can see the sorts of things that we've put down there. This is partly about strengthening leadership. It's about building relationships and managing conflicts, because so much complexity is socio-political. Co-developing vision, so the bits about co-design are absolutely in there. developing individuals to be creative. You know, the solutions are often going to be made by the frontline staff, you know, the kind of people that are listening in on this talk, actually. Minimizing scope creep is important. Who's been in the technology project that's just got bigger and bigger and bigger, and also addressing things at national level that might make the context a bit more conducive. Now, I'm definitely going to stop there because that's pretty much my last slide anyway, but I think there might be some interest in this complexity assessment tool, or I can go back one slide to give you the NAS framework diagram. And yeah, let's have some questions.
Should we go back a step and just pick up a couple of questions from earlier about the relationship between the elements?
Yeah.
Yeah, there was one by, just trying to find one from Andrew Sidley. Are you there, Andrew? Do you want to ask it, or shall I read it out? Yeah, so a question, using NAS, is it possible to have a mix of complexity depending on the domain, e.g. complicated condition, simple technology, complex proposition?
Yeah.
In previous and current work, have you developed explanatory typologies about a new innovation to include this potential mix? If yes, how was this received by stakeholders?
Well, I think the trouble about this is that, as I said, complexity is something that can be subjectively experienced rather than something that I would parachute in and start saying that's simple and that's complex. And I think the cancer example is quite a good one, is that a patient with a particular condition might experience it as complex, or their relatives will experience it as complex, for example, if they don't have a car. Whereas I might say, oh no, you're pretty simple because you're just going to come in on that day for your operation. And so I think these things are not, this is not a tool for objectively categorizing the complexity, because frankly, who cares what I categorize it as? It's what the frontline people believe it to be and experience it as that's going to determine whether or not they're going to adopt or whether or not they're going to play ball. And that's quite important. So the unifying tool for this is not so much a checklist with a bunch of tick boxes and Likert scales, but a narrative, a rich and detailed narrative about the project in its entirety, and maybe not even the project, but the vision for the new service. And you can put whatever you want into that, because with some of these domains, the answer is not applicable. For example, many technologies and projects don't have a particular condition. You know, the condition isn't an issue. It's because it's not a patient-facing technology, for example. But yes, certainly complexity can occur across all domains, or it may be just one domain.
We may have already answered this, but by what you've just said. But there were some questions about from Scott McLean about whether any of these domains have a greater likely predictor on the success of a project. So if you can try and simplify one of them, is it likely to make more or less difference?
Oh, interesting.
And in terms of another question about whether the complexity, whether it makes a greater difference if you think about complexity from the perspective of, say, the clinician or the patient.
Yeah, I mean, I think because technology projects in healthcare are so diverse that you can't say one is more important. But one of the things that I found in the literature was that the commonest reason for technology projects to fail is that clinicians refuse to use the technologies. You know, if you want one thing, that unless you've got on board the clinicians, and I don't just mean doctors, you know, there's some, Fliss Hendel's done some brilliant work showing what happens when midwives refuse to use technologies on labour wards. I mean, they just don't get used, and that's that. So there is that. And interestingly, the GPS tracking, you know, we had so few people recruited into that study because some of the social workers were opposed to it. Not all of them. In fact, it was, you know, some of the social workers came up with the idea, But if the staff are not going to play ball, that's seriously problematic. On the other hand, there's also the question of if you've got an organisation that is dysfunctional and it's got poor leadership, that usually means that they're not going to be innovative.
We have a lot of questions for people asking for maybe specific links or a little bit more detail, but I suggest we follow up after that rather than bring those into the conversation now.
Yeah, sure. I have written, I mean, the paper that I'm referencing here, you can just see it. Actually, it doesn't show the reference, but I have written a simplified guide to this. I hope that doesn't sound patronizing, but the original paper was sort of full of theory and it had about 100 references. And someone said, look, you really need to write kind of a 3-pager for people who don't actually need the academic details. So one of the things I could do is send that to Matt and you could send it around. But certainly the NASCAT tool is being developed at the moment by a group called Habitat in Leeds, who are sort of hands-on people who facilitate change in the NHS and social care. And it's being tested by various groups who are going to be piloting the NASCAT tool over the next year or so. So that's all work in progress, really.
We have an awful lot of comments. It's a very live discussion thread, but a little bit difficult to tease out specific comments for the conversation here.
While my colleagues think that through, I have a question to throw in, if that's all right. Hi, it's Will from the Health Foundation. Trish, we fund a lot of teams. In fact, you're part of one of them, a team from Barts.
You fund me, thank you very much.
And we've got some people on the call who are leading similar projects. And I wondered what you might have to say about the characteristics of the individuals and the teams who are leading and trying to get wider adoption of technologies that they might have developed or trialed in one place, and trying to take that up to scale based on this framework. What sort of characteristics do those teams need to manage this complexity?
Quite interesting. Well, I'm the academic on the team, so I'm probably the least qualified to comment on that. But what I have been quite impressed with, I've been working with the Barts people for nearly 20 years now. We've been doing video consultation work for 9 years, and there's certainly the product champion or the champion role has been very well illustrated by some of the staff at Barts. There's been one lead nurse, there's been one lead consultant, who are just massively enthusiastic about this technology. They believe in it, they've got infectious personalities, they talk about it, they rave about it, they talk about its potential. So I think that the champion is very important, but there's also somebody who understands how the organization works and how to get stuff done here, in this organization. And you know what I'm talking about. I mean, when I started at Oxford University, I tried to get things done the way I had been getting things done at Queen Mary, and that's not the way things work at the University of Oxford. At Oxford, it works by going to dinner in someone's college, and you have to start dining to get things done. Anyway, the way things work at Barts, I now know, and I learned from Shanti, actually, who's the NHS principal investigator for our study, is you get your project on the agenda of every single committee, and you get it as a rolling agenda item, and you get yourself invited to attend the committee and report on this rolling agenda item. And Shanti was very good at just getting our video consultation project on the key committee agendas. Now, I would never have thought of that because I don't work in the NHS, but that's just one example of someone who knows what makes the organisation tick and also knows which committees to play. The other thing that they did well And again, I think it was driven by instinct rather than by an evidence base, because we retrofitted the evidence base to what they'd already done. Is they set up a central support unit, and I can't remember what they call it, but it's called something like the Video Consultation Support Unit, which is a kind of central team that if one particular clinical service wants to set up video consultations, this central team would then go out and visit them and transfer the knowledge they'd learnt from the other teams. So that was quite a structural change and an important thing. So I guess it's partly to do with what kind of personality you've got, but it's also to do with how long have you been working there, and do you really know how change happens in this organisation? I bet there's some other suggestions on the chat, but I can't see it because I've got my PowerPoint in front of me.
We're almost up to time, Trish. So I think if you've got any sort of quick thing you want to wrap up with, and actually people, if they want to join the SIG, the Closing the Gap SIG, they can kind of ask questions there and put them maybe there as a way to continue the discussions. But we need to sort of wrap up in about 1 or 2 minutes. So any comments from you about next steps and what we should be thinking about?
Well, I've just got my 3 take-home messages, because I've been on one of those talks that you have to have your elevator pitch. That if everything was simple, we probably wouldn't need to be having this webinar, but it's never simple because, hell, illness is complex for starters, never mind anything else, which is why it isn't like doing your shopping online. Complicated, yeah, if it's just complicated, you probably will get there, but it'll be slower and harder and more expensive. But the problem with complex, where you've got all these, non-linearity, unpredictability, interdependencies, it may well be impossible. So try and reduce complexity as much as possible. And if you can't reduce it, then, develop your staff, develop your teams, have that spare capacity to take an adaptive approach. And that's what we're developing the NASCAT tool for.
Brilliant. Thank you, Trish. That was wonderful, wide-ranging. I think we were still getting deeper and deeper. We need a new framework just to categorise the comments and questions in the chat box.
Yeah, I bet we do.
But so thank you, everyone, for joining us. Look out for future Zoom calls we'll be running as well. We're just kind of working on them. Thanks, Trish, so much for your time.
Thanks for inviting me, and thanks, everyone, for joining in.
Yep. Thank you, everyone. See you all soon.
Cheers. Thanks, guys. And now, Matt, I'll send you that paper so that you can send it around to the people who are registered.